Thank you very much for the invitation to speak today. Now, I am guilty of having about 150 slides that I've got to talk about in 30 minutes, but I'm going to make all these slides available. And just where am I going to make them available? Just before I do that, could I just have a show of hands? Who's interested in cancer prevention and screening? Everybody. How many people are members of the Scottish Cancer Prevention Network and that they get the quarterly newsletters? Okay, well, not enough of you. So what I'd like to do is to get your email addresses for those of you that don't already get our free quarterly newsletter so that we can sign up, because it builds on what I'm going to say today in terms of updating, and that's where I'm going to put this presentation. So if you miss some of it, and I know you'll say, oh, she went through it too fast, then that's where to go for it. And the network is a Scotland-wide network, and it's very much about advocating and supporting change in Scotland. It's not just at an individual level working with patients, but a bit of government lobbying as well for the areas that we know are so important in terms of cancer change. And for those of you that tweet, we welcome followers, and it's at the SCPN. So that's my plug, and I'll look forward to emailing you and so on. So what about global cancer burden? I think we have to take a worldwide view when we're thinking about cancer, because we are very focused in the Western world on screening and treatment. We know it's really expensive. So much research goes into clinical intervention, exciting new technologies. And if you look where research investment is, it's in the science. But actually the work that we all do in terms of behaviour change is much more difficult than the science. And in terms of primary prevention, we know from a cost perspective that we've got to look at lifestyle interventions, the much broader environment that we live in, as well as things like immunisation and chemo prevention. These, of course, are exciting areas, but actually at the coalface, it's how do we even initiate behaviour change. And we've got this fantastic work in Scotland, and I'm going to illustrate this with some breast cancer. We've got the Detect Early campaign, fabulous screening programme, better treatments, better survival. But actually, the reality is that we have about 4,500 women in Scotland diagnosed with breast cancer. It's the most common cancer. The incidence rates have increased by about 14%. So while we're busy detecting early and screening, what about prevention? Just what is being done there? Can we prevent the disease? Now, I'm going to show you the evidence about estimates and prevention, but I argue that if there was a drug that reduced breast cancer risk by 42%, we would all be talking about it, we'd be interested to know whether we should be on it, we'd be discussing it with our health professionals, and I don't think that that happens in practice. And we would want women of all ages to take that drug in order to stack the odds against developing cancer. All the lifestyle stuff I'm going to talk about, I can't say it's going to prevent people getting cancer, but it can move the risk. And I think that's a really important message, because you always find people saying, oh, you know, Auntie Nellie, she lived to 110, she drank and smoked and she was absolutely fine. You know, it isn't a pure case of if you do this, something's going to happen, if you don't, something else will. It's about changing the risk. When I think about cancer causes, when I teach my medical students, this is the list of things that we talk about, all very recognisable, good science behind it. Everybody's comfortable with that. Everybody knows about tobacco, and of course in Scotland we've got this really visionary tobacco strategy. And I'm not going to say any more about tobacco today because I want to focus on some other lifestyle aspects, but of course that's top of the list in terms of cancer prevention. But in terms of other diet and lifestyle, there is a huge body of evidence about diet and physical activity in cancer. Now, you would turn on the radio this morning and hear one thing and say that's totally different from what I heard last week. What do I know is the right story? And the World Cancer Research Fund reviewed all the available evidence relating to diet and physical activity, and that's cancer of 17 sites, and it's about 80% of the incidence and deaths worldwide. If you want to think, if you want to find out where the current evidence is on diet and breast cancer, this is the place to go. They have a website. It is the most comprehensive view. So don't think, oh, you've heard one study result on the radio. This is actually the work that the review does, puts it all together. And they've carried out a whole load of systematic reviews and a separate judging panel and with predetermined criteria. I am very keen to promote this because I was an external observer on this panel, and I saw this panel at work. I saw experts from across the world agree on what the evidence is. So I get very cross when I hear somebody saying, oh, this one study shows us something, because it's the totality of the evidence. This is a complex slide. Across the top we've got these 17 cancers. Down the side we've got any diet or physical activity exposure that has been related to these cancers. And I'm not going to go through all of them, you'll be pleased to hear, but I do just want to distill in two things. One is that there are a lot of different dietary factors have been looked at in terms of cancer, and actually very few of them come up as being really significant. So you're forever hearing people that say, oh, I take a lot of grapefruit because it will help me prevent, if we want to look at what the evidence is, it's here. And let's hone in to what the evidence is, firstly for breast cancer. And from the WCRF report, the total estimate is about 42% of breast cancer is related to diet and physical activity. And when I said earlier, if there was a drug that prevented 42% of breast cancer, we'd be talking about it. This is the evidence on diet and lifestyle. And at the top there is alcohol. And of course, breast cancer, it's a genetic environment interaction, so it takes both to initiate the disease. And the same with bowel cancer. A wider range of factors here, but the current estimate is it's actually about 47% of bowel cancer. And what are we talking about? We're talking about foods containing fibre, red and processed meat, again alcohol, physical activity and body fatness. And it's these factors that I'm going to go through in a little bit more detail. Obesity in particular. Now, this is the relative risk of 7 cancer sites in relation to excess body weight. And it isn't just that there happens to be a relationship between the two. We can actually identify mechanisms that are in place. I've already mentioned the bottom two, breast and bowel cancer there, but right at the top, cancer of the uterus. Obesity plays a major role in this. And in fact, the Select Committee report on obesity almost 10 years ago said that obesity is far and away the most important avoidable cause of cancers in non-smokers, and it will eventually become the main modifiable risk factor as smoking diminishes. And yet, so few people are aware that obesity is so important in terms of cancer risk. Now, and then the next question people ask is, well, if I lose weight, will it reduce my cancer risk? Now, this is 3 studies that have looked at situations where people have lost body weight and looked at the cancer risk reduction. And you're probably thinking, oh, what do they do to reduce 32% of their body weight? Well, these are people who've undergone bariatric surgery. Now, I am not recommending bariatric surgery. I'm just using this to point out that where there has been weight loss, then that is associated with cancer risk reduction, notably in women. And for all the hormone-related cancers, losing weight will help to reduce that risk. So the implications of this is that weight loss has a fairly fast effect. These are relatively small follow-up periods. The higher the weight loss, the greater risk reduction. And weight loss is effective independently of physical activity. Now, Anna's going to talk about physical activity later, but weight loss is absolutely at the top there in terms of cancer risk reduction. Preferably weight loss by diet and physical activity, not by bariatric surgery. And around a quarter of all cancers is estimated are avoidable through appropriate food, nutrition and physical activity. It varies by country because each country have different lifestyles, and it varies by different site. So we can see there that breast cancer in the UK, about 42%. That review that I mentioned was done quite a few years ago now, but WCRF do have something called the Continuous Update Project, and their next set of data that will be coming out is breast cancer survivors, and I think that's one that a lot of us will look forward to seeing. But just in terms of the evidence base there, this is the number of articles just from one particular type of study, cohort studies, that were reviewed by WCRF in their update report. So when they produced the report in 2007, if you look at breast cancer, there's 328 cohort studies. Up to 2011, there's an additional 323. So there's a huge amount of evidence out there that people have to get to grips with. And that's why looking at one study really isn't helpful. But the other thing that always strikes me when I look at this data is, think how much money it's cost to do this research. Cohort studies are studies of people that are followed up for 10, 20, 30 years. Imagine the billions it costs if you look at the results from over 600 cohort studies. And this research produces the evidence that we're talking about today. What's the point of having the evidence if we don't put it into practice? So I think we've got so much research, we really now need to be investing in practice, both at a policy and practitioner level. I'll miss that. One of the points of, just going on the obesity issue, that WCRF point out is that there's a 5% increase risk of breast cancer with every 2 BMI points. So a woman weighing 30 at a BMI 30, that's the obese category, would have a 13% increased risk compared to somebody just at the overweight category. It makes a difference, it's important. Okay, so just in terms of the evidence, I haven't gone through individual studies because we've got that review. It's the most authoritative review. The continuous update work maintains the currency, and you can look at that. It's all available online, and that provides the basis for public health action. And of course, from that evidence, there's a series of recommendations, and right at the top there, as you would expect, is body fatness. And body fatness is it represents physical activity, be as physically active as possible, and limit food and drinks that promote weight gain, and then start to think about the fruit and vegetables, fibre, limiting alcohol, red meat, and so on. And also recommendations for cancer survivors. Too often, if I'm talking about diet and cancer, people say fruit and vegetables. Now, fruit and vegetables are important, but obesity is up there at the top. And I'm going to say a little bit more about cancer survivors, because I think this is a very, very important group. And we now have many cancer survivors, many people living for more than 5 years, and breast cancer is a very good case for that. But how do we maintain health and try to avoid, stack the odds against recurrence? Well, there's a series of recommendations for cancer survivors. The American Cancer Society is probably the one that's used most often. And right again, top of that list, achieve and maintain a healthy weight, regular physical activity, and a varied diet. The American College of Sports Medicine, which I think Anna will say more about recommendations and so on. But what we have here is a consistent message. Be active daily. Get activity up to at least 150 minutes a week. Look at vigorous activity as well as muscle strength and so on. And there have been trials, there have actually been diet trials of women who've had breast cancer following intervention, following a perfect diet, if you like. I'm not sure about perfect, but the sort of diet that we think would be associated with reduced recurrence of breast cancer. And one of the big ones, the Women's Intervention Nutrition Study, both are American, the WIN study, a lifestyle intervention reducing dietary fat with modest influence on body weight, showed some indication of relapse-free survival of breast cancer in women with conventional cancer management. And the Women's Health Eating and Living randomised trial, that's the WHEL, really didn't show very much difference at all. And the difference between the two studies is that we have some weight loss in the first one. However, further analysis on that second study did show that people who followed the diet and exercised actually had lower recurrence and better survival. Women with the lowest level of vegetables from carotenoids had the highest risk of recurrence, and some issues about other vegetables, cruciferous vegetables as well. So we've a lot to learn in terms of diet, but it does seem that obesity is at the top. Just in terms of physical activity, because there's 2 diet trials, but there are no long-term trials of exercise and cancer survival yet. But there's a lot, and I'm sure Anna will say more about this, in terms of interim outcomes like body composition, quality of life, reduced fatigue, emotional distress, and lymphedema. So a lot of worthwhile things, but we haven't yet got that long-term data on recurrence. This time, observational studies, a number of these are growing, and these are the sorts of evidence that WCRF will put in this review for breast cancer survival. But here's an interesting one, a Canadian study, follow-up of women who've had breast cancer. Women with better quality diets had a 60% reduced risk of death from any cause, 88% reduced risk of death from breast cancer. Add in physical activity, and those figures are just too good to ignore. Why wouldn't we be promoting exercise and good diet in women with breast cancer? And preferably, of course, the same recommendations before women ever get cancer. Dietary supplements, a lot of people ask about, and this is true both with respect to primary prevention and recurrence. The big message there is beware. Lots of people, particularly breast cancer survivors, take supplements. It's unlikely to improve outcomes unless people are really undernourished. But for most people, it's unlikely to improve, and it may actually increase mortality. And we do have a number of trials where taking supplements have actually gone in the wrong direction. It's increased recurrence. So we be very, very careful with supplement use. That's all the evidence I want to talk about. I just want to move on to a series of slides about this, the big thing that we all jostle with, which is translation into policy and practice. Now, in terms of diet and lifestyle, I think we have a lot to learn from tobacco control. And in tobacco control, we do, of course, have programs. We've got cessation, we've got prevention programs. We've had about 20 years worth of programs, and it's because they've been there for such a long time, and we are virtually all aware of the message on tobacco, that we've been able to get good advocacy, litigation for tobacco companies, and we've got the politicians now on board saying, yes, we'll do something about marketing, we'll do something about where people can smoke, taxation and so on. But you can't start at that level because the politicians will be voted out. So I think it's really important that not only are we aware of issues around obesity and physical activity, but actually we're all active in making it clear that we support this sort of environmental change to help our patients achieve better lifestyles. The WCRF, I mentioned their science report, but they also produced a policy report reviewing evidence from across the world on where changes have effectively been carried out with respect to behaviour change. And what they say, I think, very clearly is that it's no one individual's prevention's no one individual's responsibility. I've circled health and other professionals because that's us here today, but everybody has a role to play. Having said that, we shouldn't say, oh, it's all government, or it's up to the schools, or it's what the food industry do. We as health professionals have a role, and I think it's really important that we enact that role. WCRF indicate, we should prioritise public health, take a lead in educating, involve people as family and community members, and so on. And in terms of getting that message over, particularly around changing physical activity and excess weight, the health professionals have had a very clear lead in tobacco, and we have this Surgeon General's warning in the States, we have messages in cigarette packets. In the US we have very prominent medical people saying obesity is unacceptable. But where do we see that in Scotland? Where do people stand up and say, obesity is related to cancer? We do have the Health Promoting Health Service, and this concept that every healthcare contact is a health improvement opportunity. And I hear many of my colleagues, I work in Ninewell, saying that's all very well, but I'm too busy treating the patient to move back a step and start to talk about health improvement. And yet we know when it comes to weight that people are more likely to practice weight management if they've been told by a health professional what their weight is. So this is a study of about 17,000 adults. It's American. 23% of overweight women, 48% of overweight men perceived themselves as the right weight, not interested in knowing about weight because they thought they were doing okay, thank you. And I think we'd find that for many of our clientele that will work as well. 74% of overweight and 29% of obese adults had never been told they were overweight or obese. Now, these people must have been through GP practices and all kinds of different healthcare settings, but nobody had actually had that conversation. And maybe later when we're talking about communications, having that conversation is the issue. Weight control was linked with healthcare professional diagnosis of overweight and obesity. And weight control was associated with knowing they were overweight. So we need to deal with the elephant in the room. Of course, there's at least 2 reports this year from medical colleges saying we need to take action on obesity. And my own area of interest is action in the screening setting. We published this paper earlier in the year, promoting changes in diet, physical activity in breast and colorectal cancer screening, an unexplored opportunity. I'm just going to very quickly flag up some of the research that I do because I think it provides some interesting illustration. This is a study that we're just in the process of completing. We're analysing the data. It was a weight loss trial for people who had colorectal adenomas done at 3 sites. So we had Glasgow, Ayrshire, Nairn, Glasgow, Forth Valley and Tayside. And we reckon this was a teachable moment. People had an adenoma, wasn't a cancer, but they'd had a bit of a scare. They are at higher risk of cancer and other obesity-related diseases, and it's got a whole load of people here. Prior to running the intervention, we undertook some focus groups in Tayside, and these were people, the sort of people that were going to be running the trial on people who'd had an adenoma. Small studies, 50 to 74, because that's the age range, of course, of screening, and people who are overweight. And this is just some snippets from some of the focus groups. So we have the moderator there saying, so if someone said to you that you'd had polyps removed, now let's look at your diet and physical activity, what do you think about this? And the participant saying, well, if they said, now that is caused by diet, let's look at your diet, that's fine. But nobody at any time has said it was caused by diet. So these people have gone all through screening, they've come in for their colonoscopy, met a fantastic colonoscopy staff, out the other end being told, don't worry, you don't have cancer, come back for screening. Nobody mentions lifestyle. This is another one, reading from the letter of invitation. We have to have all our correspondence to participants approved by ethical committees. And our letter said, and we had to say this, you do not have bowel cancer, and the fact that you've had the polyp removed makes it unlikely to develop the cancer. So the patient said, well, to me that tells me I'm all clear. Why do I need to change my diet? My diet's all right. There's a mismatch. If diet had caused this, I would go along with the change. So actually people are very sceptical, By not saying anything, it's almost like a health certificate saying, you're okay, we don't have to bother about that. And this is somebody saying, you said you could shed 7 pounds and give me a diet sheet to work on. And the moderator saying, what do you think? Is that a good idea? Excellent idea, because you tend to look at yourself and think, I'm putting on weight, but you don't. If someone tells you, let's see if we can get this weight down. Now, these are all people that, as I say, have had a bit of a scare. But one of the I think, very encouraging things when we were doing this study, so we approached just over 1,000 people who had adenomas in these 3 sites, saying, would you be interested in lifestyle study? 50% of them, well, 49% actually, said yes. Now, of all the trials I do, I never get uptakes like that. This group is interested, and yet nobody has said anything to them. So we have a window of opportunity that's ignored, and without patient education, as I say, I think it's a health certificate effect risk. We're also running another study here in Glasgow and in Tayside, some of you may know about this, in the breast screening setting, offering, again, lifestyle intervention for women coming through the clinics. We have a much poorer uptake on this study. We've just about finished recruitment. We'll get our numbers, but the interest is much less. And yet breast cancer screening staff have been very involved with this. Very involved, but they're very busy, and this is not their work. So we have a lot to do in terms of putting screening and prevention together. And we have one last study that I'm doing, which is in family history clinics. We have people coming forward because they have a family history. They may have been referred by a GP. They may refer through other services. They get assessments done, they get screening done, they do not get lifestyle advice. Should this be a setting that lifestyle advice is given? And just finally, last few slides, right through the other side about what people who've had cancer think about getting lifestyle advice. And this is work funded by Bowel Cancer UK, and lifestyle issues for colorectal cancer survivors. And this again was focus group work done across the UK. Bowel Cancer UK recruited people from very young, 27 up to 84, but most were retired. Mean BMI of 26, so that's about average for the population, overweight category. And the mean time from treatment was about 18 months. So they'd all had quite a long spell since they'd finished treatment. And I really want to illustrate the diversity of views that participants put over, and I think this might be very familiar to not just people who have got cancer, but the general view about changing diet. And I've used the phrase this afternoon, stack the odds, quite a lot, and this is because it came from one of the participants. You've got somebody saying, some dietary advice? I would have thought, I'd like to stack the odds in my favour. And then we have people saying, it's all very well, I need to go and exercise, but maybe knowing what it is you should do, something more specific. It's just not good enough to say, go and be more active, get involved in something. And people saying, it should be reviewed in 6 months, how are you getting on, how are you feeling about your programme. Just don't drop people, give them something in hospital and then no follow-up at all. And that's true with any setting when we give advice. Monitoring and some form of feedback is much more likely to be effective. And then when people have looked for resources, they get American stuff. They would have liked things that are more local. And then we've got people going off in another extreme. I try and buy organic food as best as possible. Get a lot of berries, beetroot, more fruit and vegetables. Come on, where's the basic information that needs to get through about healthy eating? And for all, and so it isn't some weird and wonderful thing. And here's a different set of views. Essentially, we have the same diet at home before and after the cancer diagnosis. It's a sore point with me. Whenever diet is mentioned, there's some sort of explanation for bowel cancer. I think it sort of stigmatises people. And otherwise, it says, your diet was poor, that's why you've got the cancer. And that is a really difficult one to handle. And it's really important that we look forward, not looking back, and avoiding all blaming. It's a clean sheet. Let's do what we can to stack the odds. I don't think healthy diet will make any difference personally. I take the view it's the luck of the draw. And I just think it's almost bad luck, really. And I could show you endless slides with that sort of phrase on it. People saying cancer, it's fate, it's bad luck, it's in your genes. They don't say, 42% breast cancer could be reduced with diet and lifestyle. We are really not getting that message over. Okay, so how well are health professionals trained to deal with patients' feelings of guilt or disbelief? Can we avoid victim blaming and move towards that positive approach? Is it too late to talk about risk reduction after diagnosis? And do we ignore opportunities to talk to families? A lot of work about if a woman is diagnosed with breast cancer, about her sister or her daughter and so on. Well, there's an opportunity. We can't do anything about genetics, family history, but we can modify a lifestyle. And are we trained to deal with that? And that's part of our issue today. And is giving lifestyle advice something cancer care professionals should do, can do? I'm just going to finish here, but we talk about the wider environment and the health profession. We talk about the health promoting health service. Where are we with the role models in the health profession? Some of you may remember the Carry On films with the matron there and the surgeon, both in the large size. And of course, what else goes on in their hospitals? W.H. Smith, and we have one in the concourse in Dundee, always keen to promote sedentary behaviour along with excess energy intake. So many hospitals with McDonald's. So it's not just what we say, but it's also the environment that we present to our patients. So in conclusion, there is significant evidence to support targeting, and this is in addition to smoking, diet, physical activity and weight management in cancer control programs. There's promising evidence to support lifestyle change in cancer survivors. Interventions to change lifestyles, everybody's business. It's not just us as health professionals, but health professionals have opportunities to promote and endorse changes in lifestyle within the context of the health promoting health service. And I would argue that really remains to be developed, but I'll look forward to seeing it. Thank you.